you an approach that helped me already a lot, and it's very useful and easy to remember. It's very hard to cover the whole the two joints, the ankle and wrist, in 1 hour, but I'll try my best to cover at least the basic anatomy and some common pathology. I know some of you already know how to read these two joints, but you can consider it as a healthy revision. Let's start with the ankle MRI. First, I got two cases just to look at it and challenge yourself. First case is young male patient with medial ankle pain. And the second case is worsening ankle pain, and we got two sagittal and one axial cut. We will answer these questions at the end of the session. Like any other joint, we have a checklist when we evaluate the ankle joint. We cover the bones, so screening for bone marrow edema, contusion, fractures, osteochondral defects, alignment, and accessory ossicles. We also assess the joints, tibiotalar and subtalar joints, screening for an effusion, joint space, cartilage, and loose bodies, and assess each ligament and tendons. First of all, I will start with this diagram, very useful to begin our discussion about the tendons. هو عبارة عن schematic drawing of transverse section at the level of distal tibia and fibula, as mentioned here. We basically divide the region into 4 quadrants, which will show the major tendon that cross the ankle joint, but of course not all of them. So in the anterior compartment, we have the extensor tendons. Starting from the medial aspect, it's tibialis anterior tendon, extensor hallucis longus, and extensor digitorum longus. In the posterior aspect, we have the Achilles tendon. On the medial or posteromedial aspect, we got the flexor tendons, which are the tibialis posterior tendon, flexor digitorum longus, and flexor hallucis longus. And on the lateral aspect, I got the peroneal groups, which are peroneus longus and brevis. I like this drawing also because it also emphasizes on the size of the tendon. As we can see here in the medial aspect of the tendon, we see the tibialis posterior is almost double the size of the other flexor tendons. Yeah, nearly double size, not more than that. And we have only 3 tendons in the medial aspect. Because one of the ways to assess tendon pathology is to look at the size of the tendon. The tendons generally have similar course throughout its course, similar size throughout its course, but only it might change in the caliber in different location when it divide or branch, or when it passes through a groove, or at the site of ossification. This is exactly the same MRI cut like the diagram shown earlier, showing extensor tendon anteriorly, flexor tendon medially or posteromedially, peroneal tendons laterally, and Achilles tendon posteriorly. I made this slide to facilitate analysis of each compartment and its content. Like in the anterior compartment, as we mentioned earlier, we have the extensor tendons, but we don't have ligaments. While in the posterior compartment also, we don't have ligament, and we got only tendons. So anterior and posterior compartment, we got only tendons and no ligaments. In the medial compartment, we have flexor tendons, and we got one important ligament, which is deltoid ligament. The lateral compartment, we have the peroneal tendons and two group of ligaments, which are the tibiofibular syndesmotic ligaments and lateral ligamentous complex. Let's talk about individual tendon, starting by the posterior compartment, which is an Achilles tendon. The Achilles tendon is the largest and strongest tendon in the body. It's conjoined tendon of gastrocnemius muscle and soleus muscle. Always the gastrocnemius muscle located more posteriorly and the soleus muscle located anteriorly. It inserts on the posterior calcaneal tuberosity, and the retrocalcaneal bursa usually located between the distal end of the calcaneum and the calcaneal tuberosity. And we have the critical zone where there is a diminished or decreased blood supply, and usually it's located about 2 to 6 centimeter from the calcaneal attachment, which means it makes it more prone for injury, rupture, or delayed healing. The most important thing is the Achilles tendon is surrounded by partenon, not like other tendon where the tendon usually covered with the tendon sheath. So if we have fluid signal intensity around the Achilles tendon, we will not call it tenosynovitis, we call it peritonitis, and some people call it peritonitis. How does the Achilles tendon looks like on MRI? The normal MRI appearance of the Achilles tendon should be smooth, with low signal intensity on all pulse sequences. It's surrounded by clear fat pads, both anteriorly and posteriorly. On the axial plane, we should have a concave anterior margin of the Achilles tendon, and usually we measure the anterior and posterior dimension. And the normal thickness shouldn't exceed 7 millimeter. On the sagittal plane, I should see a parallel line of the anterior and posterior margin of Achilles tendon below the level of soleus insertion. Let's see an examples. In the first case, we see a thickening and loss of the concave anterior margin of Achilles tendon, and this case denoting tendinosis. The second case demonstrates thickening of the Achilles tendon with intermediate internal signal intensity. I'm not sure if it's clear here, but it's intermediate speckles of internal signal intensity along with thickening of the Achilles tendon. This represents degeneration. And the third case, there is a rupture of the Achilles tendon with a fluid-filled gap between the torn ends. And this is at the critical zone. The other tendon in the posterior compartment, I didn't mention it earlier, it's a smaller nearby tendon called plantaris tendon. And it is the longest tendon in the human body and absent in 7% of people. Insert on or medial to the Achilles tendon. Regarding the anterior compartment, we have the extensor tendons. Usually the people like a phrase Tom, Harry, and Dick. And then when they go to the flexor tendon, they flip the phrase to Tom, Dick, and Harry, which represent tibialis anterior, extensor hallucis longus, and extensor digitorum longus. We should see it as black, low signal intensity structure along the dorsum of the ankle. The medial tendons, it's the flexor tendons. As we mentioned earlier, the starting medially by tibialis posterior, and then flexor digitorum longus and flexor hallucis longus. The tibialis posterior tendon support the medial longitudinal arch of the foot. So if we got an acute injury to the tibialis posterior tendon, the patient might represent with acute flat foot. The tibialis posterior tendon shares a tibial groove, as mentioned as a blue line, with the flexor digitorum longus, and usually double the size of the flexor tendon. Regarding the ligament of the medial compartment of the ankle joint, we have the deltoid ligament, and it has two parts, superficial and deep part. Usually appears on MRI as striated and fan-shaped appearance, and best seen on coronal images. This is coronal T1 weighted images and demonstrate the linear low signal structures. The deep layer connects the inferior border of the medial malleolus to the medial side of the talus. Caudally connected to the spring ligament, which is served as a hummock for talus, and the spring ligament is oriented obliquely and has a close relation with the deltoid ligament and tibialis posterior tendon. Here are different examples of deltoid ligament. The first one here we got normal deep deltoid ligament with striated and fan-shaped appearance. In the second image in the middle, we see blurring and no clear delineation of the deltoid ligament. And the last image, there is total discontinuity and fluid signal intensity of the tendon associated with subjacent bone marrow edema. This is a higher grade injury. The lateral compartment involves the peroneal tendons, which are peroneus longus and brevis. They both located in the fibular retromalleolar group. Typically, the peroneus brevis tendon is located anterior and medial to the peroneus longus tendon. مما يعني إذا كانوا الاثنين في نفس الcut behind each other, so always the peroneus brevis tendon is located anteriorly. وإذا كانوا موجودين on the same level, the peroneus brevis tendon usually in the medial aspect. Let's talk about the ligaments of the lateral aspect of the ankle. First of all is tibiofibular syndesmotic ligament. عادة تكون at the level of talar dome. هي ال communication between the tibia and fibula. فبالتالي حتكون anterior tibiofibular ligament and posterior tibiofibular ligament. And we have two more ligaments, which are inferior transverse ligament and interosseous ligament. I will talk about each one separately. The other group, which is lateral ligamentous complex, حتكون lower than the syndesmotic ligaments and communicate the talus with fibula and calcaneus with the fibula. And they are anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligaments. Let's begin with the tibiofibular syndesmotic ligament. As we see here at the level of talar dome, this is the tibia and this is the fibula. And this is the anterior tibiofibular ligament, and this is the posterior tibiofibular ligament. Usually in sport injury, they call it high ankle injury, and best visualized on axial images at the level of the talar dome. How in ligamentous injury, how does it look like in acute injury, and how does it look like in the chronic injury? In acute injury, the ligament might be absent. Maybe we see a laxity of the ligament. We might see partial disruption of the ligament, and usually it's associated with surrounding edema and fluid with possible underlying bone injury or contusion. In chronic injury, usually we see the ligament thickened and can be of normal signal intensity, and we might see a scarring. In the first case, we have an axial image of the ankle at the level of talar dome, demonstrate normal and intact anterior inferior tibiofibular ligament. It's continuous with preserved low signal intensity. The second image, we can see partial tear of anterior tibiofibular ligament, which shows a fluid signal and thickening and also irregularity of the ligament. The third image demonstrates discontinuity of the anterior tibiofibular ligament at the same level and indicating complete tear of anterior inferior tibiofibular ligament. Regarding the lateral ligamentous complex, the anterior and posterior talofibular ligament usually best visualized on axial images and best seen on malleolar fossa. The malleolar fossa is where the clavicle looks like a comma shape or concave medial margin on the axial plane. We see the anterior talofibular ligament, which is the weakest of the lateral ligament, and usually it is um, 2 millimeter thickness, while the posterior talofibular ligament is the strongest and has linear striation on axial PD images. This is an example of tear of talofibular ligament where we can see discontinuity of the ligament at the talar attachment with retraction of the ligament. It is associated with fluid at the anterolateral gutter, and the posterior cruciate ligament, the posterior talofibular ligament, sorry, is preserved in this case. In the second case, we have a complete tear of the anterior talofibular ligament with discontinuity of the ligament. And also we have a partial tear of posterior talofibular ligament with edema and loss of the striation associated with fluid in the anterolateral gutter. And the last one is calcaneofibular ligament, which is best seen on coronal images. This is a coronal stair. Images clearly shown the calcaneofibular ligament attaching to the lateral malleolus and calcaneum, and usually it is 2 millimeter thickness, and isolated calcaneofibular ligament injury is rare. This is an example of a torn calcaneofibular ligament. You can see here a blunt, ill-defined structure just inferior to the lateral malleolus, just superior to the remnant torn calcaneofibular ligament. Sinus terci. Sinus terci is a cylindrical cavity which is located between the talus and calcaneus on the lateral aspect of the foot. Its component is involving the fat, ligaments, nerves, and vessels. Best visualized on sagittal T1 weighted images without fat sat, we should see a fat signal intensity and which surround the linear low signal intensity. Sinus terci syndrome, it's a clinical syndrome of pain and tenderness of the lateral side of the hind foot, where we can see loss of the fat signal in the sinus terci. And here, this is the same sagittal T1 weighted images. We can see the difference between the two cases. The first one, we have preserved fat signal intensity, and in this example, we lost the fat signal intensity, and it's replaced by inhomogeneous fluid signal intensity, representing sinus terci syndrome. Also, one of the common trauma we encounter during our practice is osteochondral lesion of the talus. It's a focal injury to the talar dome with variable involvement of subchondral bone and cartilage, resulting in osteochondral lesion of the talus. It may be caused by trauma or repetitive microtrauma. As we can see here, focal bone marrow signal alteration involving the medial aspect of talar dome. It's presented on the sagittal T1 weighted images and as edema on sagittal T2 fat sat. This is how does the normal appearance of the coronal MRI RATSAT demonstrate a intermediate signal intensity which represent the cartilage. We should assess it carefully and to look for any abnormal discontinuity or flaring. The black or dark signal intensity represent a cortex, and this is the bone marrow. Here I got an example of extensive cartilaginous lesion down to the bone with adjacent cartilaginous flap. The cartilage is disrupted in this area. And this case after arthrogram and the contrast injection, we noticed that the contrast passing through it, indicating communication. This is an unstable kind of injury. And these are the different stages of osteochondral lesions and stability. So let's get the answers of the first case. Does anyone know the answer of this case? If you know, just you can share it on the chat box. Okay. This is an axial cut of the ankle where we see the medial aspect of the tendon here. Now we are analyzing this slide. We got the posterior compartment, we got the peroneal tendons, which means we are on the lateral aspect of the foot. And here we are in the medial aspect of the foot. As I mentioned earlier, we should see 3 tendons in this compartment. But in this slide, we got 1, 2, 3, 4 tendons. And also we have a fluid signal intensity separating these 2 low signal structures. You can see it here. So again, there is an abnormal appearance of the medial flexor tendon with 2 oblong low signal structures at the expected location of tibialis posterior tendon with linear fluid signal intensity between them. The diagnosis is split tear of tibialis posterior tendon. The second case, there is a thickening of the Achilles tendon, which suggesting Achilles tendinosis. We lost the parallel line of the Achilles tendon on the sagittal planes, and also we lost the concave anterior margin of the Achilles on the axial images, and associated with internal speckles of higher signal intensity with surrounding edema and fluid. Also, we have a prominent posterior superior aspect of the calcaneal tuberosity. And on this sagittal image, we have retrocalcaneal and retroachilles bursitis. The constellation of findings representing a Haglund syndrome. It's a very painful entity and usually associated, can be seen in the ladies who are wearing high heels. Now let's talk about the wrist MRI. Checklist of the wrist MRI, we need to analyze the anatomical details of the bones, tendons, and ligaments, fractures and avascular necrosis, ligamentous injury, tendinopathy and tenosynovitis, triangular fibrocartilage injury, carpal tunnel, ulnar variance, and tumor and cyst. We have like 15 bones in the wrist joint. I know all of you know it, but just review it. We will review it in very fast. Radius, ulna, From the radial aspect, start with scaphoid, unate, triquid, trapezioid, trapezium, trapezoid, capitate, and hamate, and first through the fifth metacarpal bones. We have different joint, distal radio-ulnar joint, which articulate the distal radius and ulna at the radial sigmoid notch. The radiocarpal joint, the radius articulate with the scaphoid and lunate, and the ulna doesn't directly articulate with the carpal bones and separated with the triangular fibrocartilage. And then we got the mid-carpal joint and first carpometacarpal joint. Let's have some definition about the hand. So I will make sure everyone knows what I'm explaining now. Anything at the palm of the hand, we call it volar aspect. Palm of the palmar region of the wrist, we call it volar aspect. And the opposite side, we call it dorsum, which is the back of the wrist or hand. Anything toward the forearm, we call it proximal. Anything that goes toward the fingers, we call it distal. And anything toward the ulnar aspect, we call it medial. And anything toward the radial aspect, we call it lateral or toward the thumb. Let's start with the tendinous anatomy. I will start first with the flexor tendons. Flexor tendons are located at the volar aspect of the wrist. حنعرف اسماء حقت التندون من اللوكيشن تبعها، يعني مثلا الراديوس the first tendon here opposite to the radius حتكون flexor carpi radialis، والتندون اللي opposite للألنا حتكون flexor carpi ulnaris. اوكي طيب إذا بدأنا من الراديال aspect قلنا معناتها this is the lateral aspect، معناتها إنه this is at the area of the thumb. فحبدأ بالفليكسور كاربي رادياليس، تيجي بعدها الفليكسور pollicis longus going to the thumb. And then I have this group of tendons which are flexor digitorum tendons which divided to superficialis and profundus. And finally, as I said, flexor carpi ulnaris. So again, from the radial aspect, opposite to the radius, we have flexor carpi radialis, flexor pollicis longus, flexor digitorum superficialis and profundus, and finally the flexor carpi ulnaris. Okay, we'll do the same thing on the extensor tendon at the dorsum of the wrist. But خلينا نحط هذه two tendons على جنب. It's part of the extensor tendon بس خلينا نحطها على جنب مؤقتا. وحنبدأ من هنا من الراديال aspect. طيب أنا عندي هذه الجهة الفلكسور area flexor carpi radialis، في الأوبوزيت حتكون إيش؟ extensor carpi radialis. بما إنها اثنين حتكون extensor carpi radialis longus and extensor carpi radialis brevis. هنا عندي flexor pollicis longus حتروح بعد ال lister tubercle of the radius حيجيني اللي هي ال extensor pollicis longus. بعدها ال flexor digitorum حتكون ما حتكون superficialis و profundus، حتكون just extensor digitorum tendons and extensor digiti minimi. وهذه حتكون مين؟ ال extensor carpi ulnaris. باقي الاثنين اللي تكلمنا عنهم في البداية حيكونوا اثنين APL و ABB abductor pollicis longus and abduction، والثانية اللي هي extensor pollicis brevis. احنا قلنا already extensor pollicis longus هنا حتكون extensor pollicis brevis. So again, from the radial aspect, we have APL, ABB, extensor carpi radialis longus and brevis, extensor pollicis longus, extensor digitorum tendons, and extensor digiti minimi, and finally the extensor carpi ulnaris. I hope it's very clear and easy. Okay, the extensor tendon will be divided to compartments, and each compartment colored has different color. The first compartment involve the abductor pollicis longus and extensor pollicis brevis. The second compartment involved the extensor carpi radialis longus and extensor carpi radialis brevis. The third compartment involved the extensor pollicis longus. The fourth compartment involved the extensor digitorum tendons. And the fifth compartment involved only one tendon, which is extensor digiti minimi. And the sixth compartment involved the extensor carpi ulnaris. Here I got a case, 30-year-old female complaining of dorsal radial wrist pain. Then we will analyze this axial T2 fat sat image, and we got the radius here and ulna. So the first extensor tendon on the radial side, we have the first compartment, which involved the abductor pollicis longus and extensor pollicis brevis. We see here an increased signal intensity and fluid within the tendon sheath of the first dorsal extensor compartment of the wrist, indicating tenosynovitis. And if we got tenosynovitis at the first compartment, we call this syndrome de Quervain tenosynovitis or de Quervain syndrome. It's also known as Washerman's sprain or strain. Some people call it new mommy syndrome. It's a very painful stenosing tenosynovitis, 3 more times common in women, about 80%, and most cases are associated with overuse. Might be after local trauma, which precipitate this condition. لهم لأنهم recurrent lifting their infants, and so recurrent trauma and overuse, it will cause this condition. The carpal tunnel. Carpal tunnel is passage of the flexor tendon between the carpal bones and the flexor retinaculum. The flexor retinaculum shown here as a curvilinear red line here. It articulates the tubercle of the trapezium toward the hook of hamate. And it contains the flexor tendons, which are flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and the most important thing is the median nerve, mentioned in orange. The normal median nerve is elliptical in shape with intermediate signal intensity, and usually it lies at the polar and radial side of the tunnel. These are two cuts, T1 and T2 weighted images at the level of distal radius and ulna. We see the median nerve as intermediate signal intensity. What are the manifestations of carpal tunnel syndrome on MRI? Usually the median nerve might got swollen at the level of pisiform or got flattened at the level of hamate. If we have high T2 signal intensity within the nerve, it's a sign of carpal tunnel syndrome. And when we have a bowing of the flexor retinaculum, sometimes crowding of the flexor tendon, a loss of perineural fat pad, it's also a sign of carpal tunnel syndrome. Here is an example of carpal tunnel syndrome in a patient presented with numbness. As we can see here, axial MR-T2 fat sat shows an enlargement of a median nerve with high internal signal intensity and bowing of the flexor retinaculum. This is another example of carpal tunnel syndrome caused by a ganglion cyst. And we see the median nerve here demonstrate high T2 signal intensity. The ulnar nerve anatomy, it's outside the carpal tunnel, and usually we assess it at 3 different levels, just deep to the flexor carpi ulnaris, or at the level of pisiform, lateral to the pisiform, or at the level of hook of hamate. This is hook of hamate. What about the ligaments of the wrist? We know that the wrist joint is the most complex structures. It has lots of ligaments which are intrinsic and extrinsic, and I don't have time to cover all of them in this lecture. So I will focus on the big three ligaments. Two of them are interosseous, which are the scapholunate and unitriquetral ligaments, and I will focus on the triangular fibrocartilage complex. First, to start with the scapholunate ligament. Scapholunate ligament, it has two components, the dorsal and volar aspect. Usually the dorsal component is the thicker and stronger and most important functionally. It appears as triangular shape on coronal images and should have low signal intensity. It is weakest at the scaphoid attachment, and injury to the scapholunate ligament might cause carpal instability. If we got a tear of scapholunate ligament, we can see it on MRI with the widening of scapholunate interval, or we see a tear within the ligament, or if we got an arthrogram, we see passage of contrast from the through different compartments. This is another example of scapholunate dissociation, as we can see on the coronal CT and coronal T1 weighted images with severe widening of scapholunate space, and it's usually called Terry-Thomas sign. The unitriquetral ligament also it has two components, the volar and dorsal component. تكون عكس الثاني السكابولونيت. The unitriquetral ligament volar component is thickest portion and more important component contributing to carpal instability. فالunitriquetral الvolar compartment هو اللي stronger, and the scapholunate ligament, the dorsal component, is stronger. These are an example of tear of the unitriquetral ligament, as we see discontinuity of the ligament here with extensive passage of contrast, and we see also scapholunate tear with severe widening and non-visualization of the ligament. Now I will talk about the triangular fibrocartilage. Triangular fibrocartilage is a complex of fibrocartilaginous disc in association with several ligamentous structures. لما نقول fibrocartilaginous, it means it should have low signal intensity in all pulse sequences. It arises from the medial aspect of the radius and inserts into base of the ulnar styloid process. Injury to triangular fibrocartilage, it will disrupt the distal radio-ulnar joint and might lead to subluxation or dislocation. This is how does the triangular fibrocartilage looks like on coronal images, and this is how does it look like on sagittal images. This is another example of normal triangular fibrocartilage with preserved low signal intensity. It has different components. Triangular fibrocartilage proper, extensor carpi ulnaris tendon sheath, ulnar collateral ligament, meniscal homologue. And if we got injury in younger age group, usually due to trauma, and it usually happens near the radius attachment. The degenerative tear usually occur near the ulna in older age. I got different examples of triangular fibrocartilage tear. This is the radius, ulna, this is the radio-ulnar joint. We see the radial attachment of the triangular fibrocartilage is preserved with marked discontinuity and tear of the ulnar part of triangular fibrocartilage caused by acute trauma. Also, we have an effusion within the distal radio-ulnar joint. The second case represents a small and large central triangular fibrocartilage tear. Actually, the triangular fibrocartilage tear, they have a Ballmer classification, and it describes each tear location of the tear. You should revise it later. This case represents a partial thickness tear at the undersurface of triangular fibrocartilage. And the second case demonstrates a full thickness tear at the radial attachment of triangular fibrocartilage. We see a gap and discontinuity of the ligament. Ulnar variance, we got positive and negative ulnar variance. When the level of the ulna is longer than the radius at the radio-ulnar joint, we call it positive ulnar variance. And when the ulna is shorter than the radius at the radio-ulnar joint, we call it negative ulnar variance. There are some association with each variant. Usually, the positive ulnar variance is associated with ulnar impaction syndrome, or some people call it ulnar abutment syndrome. And a negative ulnar variance associated with Kimbok disease, which is avascular necrosis of the leonate, and ulnar impingement syndrome. This is an example of positive ulnar variance. We can see the distal ulna extend beyond the articular surface of the radius, and we can see squeezing the triangular fibrocartilage in what's called an ulnar impaction syndrome. This is the normal neutral ulnar variance where the radius and ulna are at the same level, and we see how does the triangular fibrocartilage preserve its signal characteristic. The last one is negative ulnar variant. It's clearly shown that the distal ulna is shorter than the distal radius, and usually it's impinged at the distal radio-ulnar joint and might associated with Kimbok disease. This is an example of an ulnar impaction syndrome. What will happen? It extends beyond the distal radius, so it will squeeze the triangular fibrocartilage between the distal ulna and the leonate. Later on, the patient develops cystic changes and arthritic changes. Associated finding, we might see a leonate cartilage degeneration or leonate bone marrow changes, disruption of the leonotriquetral ligament, and instability. Kimbok disease is avascular necrosis of the leonate bone. It can be presented with sclerosis where we lost the signal intensity on T1 and T2 weighted images, and as shown in this image, and it might be presented with collapse and fragmentation of leonate bone and sclerosis. In this case, we got signal loss and sclerosis as well as collapse. I will talk about one of the commonest fractures we see in daily practice, which is the scaphoid fracture. Scaphoid fracture is a very important entity because some cases developed avascular necrosis. Sometimes we got a fracture at the proximal pole, sometimes at the middle pole or at the waist of the scaphoid bone, sometimes at the distal pole, and occasionally we see it as vertical fracture. This MRI coronal image demonstrates a fracture line through a scaphoid bone with edema at both sides of the joint in stair images. Why the scaphoid avascular necrosis happens? Because as you all know, the scaphoid bone gets its supply from the distal to proximal aspect. and occurs in 15 to 30% of scaphoid fracture. Almost always involves the proximal pole. The more proximal is the fracture line, the risk of avascular necrosis and non-union increase. This diagram shows if the fracture in the proximal pole, see how much the non-union risk increased and avascular necrosis. In the middle pole, it decreased, and in the distal pole is the best outcome. And it usually this association with avascular necrosis. The radiographic hallmarks of the avascular necrosis are sclerosis, collapse, and fragmentation. MRI may be more sensitive to avascular necrosis than conventional radiograph, but it is not 100% sensitive. Here is an example of scaphoid fracture with avascular necrosis on coronal T1 weighted images. We see fracture at the waist of the scaphoid bone with sclerotic proximal pole. The proximal pole appears collapse and decrease in volume, and this represents avascular necrosis. One of the common fracture also we see on daily practice is Colles fracture. It is the most common type of distal radial fracture, usually diagnosed by X-ray, sometimes very occult and they couldn't see it and they request an MRI. It results when the patient falls onto outstretched hand, and it can happen in all age group, but most frequently in older patients with osteoporosis. This just slide demonstrate the value of each sequence. In axial plane, we look for vomer edema, scapholunate ligament, unitractable ligament, distal radioulnar joint alignment, soft tissue and ligaments and tendons. Also the carpal tunnel. On the coronal images, we see bone marrow and also the ligaments, triangular fibrocartilage best seen on coronal images, and also we assess the tendon and ligaments. On the sagittal planes, usually we assess bone marrow edema, the alignment, and also the other ligaments and tendons. These are my references, and thank you very much.
يعطيك العافية دكتورة.
الله يعافيكم، شكرا لكم.
ما في any questions.
اوكي.
شكرا.
شكرا.